Hello, everyone. This is Jeanette Gass from IASP, and I would like to welcome you to today's webinar. Today's webinar is the third in a series related to the global year about back pain. Before I introduce our moderator, I'd like to bring your attention to some information that appears on these slides. There are several ways to participate in today's webinar. After the talks, we will have a Q&A session. In order for your questions to be answered, please type your questions into the Q&A section of the Zoom meeting control panel window. You can also tweet using hashtag Global Year 2021 and follow at IASP Pain on Twitter. We have additional Global Year resources at iasp-pain.org/global year. Next, I would like to also let you know that next week is IASP's 2021 Virtual World Congress on Pain. It's free for IASP members, and it will have 36 workshop sessions with 55 CME or CE credits available. Now I'd like to introduce our moderator, Dr. Domenic. Dr. Domenic is assistant professor at San Jorge University in Zaragoza, where he teaches in the physiotherapy degree program in the Faculty of Health Sciences. He completed his PhD in 2020 at CNAP at Aalborg University and holds an MSc in research and primary care and an MSc in orthopedic manual therapy. He received his BSc in physiotherapy and maintains a private clinical practice with patients with common musculoskeletal disorders and complex pain problems. He is also a member of the Spanish Society for Physiotherapy and Pain and the Spanish Pain Society. Now I'll turn it over to Dr. Domenic.
Thank you, Jeanette. Hope you can hear me well.
Yeah, we're good.
Okay, good morning or good afternoon, everyone, wherever you are located around the globe. This is Victor Domenic, and as Jeanette said, I'm the moderator of this webinar. It is an honor that the IASP has given us the opportunity to conduct this webinar on work-related spinal pain, which is aimed at both health professionals and the general public in order to have the broadest impact. I'd like to remark that this webinar is one of the pilot actions of Prevent for Work, which is a project funded by the European Union and formed by companies and universities from Denmark, Italy, and Spain, working together to translate scientific knowledge to workers and health professionals and to prevent pain-related disability in the workplace. We have a lot of evidence-based resources that are freely available at p4work.com. The title of the webinar is Spinal Pain in the Workplace, and according to the largest epidemiological study today, the Global Burden Disease, since 1990, the numbers of low back pain and neck pain cases have been increasing, and more than 500 million people worldwide are limited due to low back pain, being also the two most common contributors to years lived with disability. This number is overrepresented in the working age population, especially in older workers and women, where low back pain and neck pain are also the most prevalent complaints in all sectors and the leading causes of sick leave and early retirement in Europe. The proportion of workers reporting being absent from work during the past year due to musculoskeletal disorders is higher than the proportion of workers without health problems. In Germany, for example, these musculoskeletal disorders, where back and neck pain are the most prevalent ones, accounted for 17.2 billion euros, around 21 billion US dollars of production loss, and 30.4 billion euros, around 37 billion US dollars in loss of labor and labor productivity in 2016. In addition to the burden for society and enterprises, and according to the European Agency for Safety and Health at Work, these musculoskeletal disorders also have a high negative impact at the individual level, affecting physical, mental, and economic well-being, and also individuals' career, family, and friends. Workers with musculoskeletal pain disorders tend to be concerned about their health and employability in their jobs. This data points out the necessity of healthcare systems to address these rising numbers that largely cause disability but not mortality. So in the webinar, the speakers are going to talk about work-related and non-specific spinal pain and the best ways to manage it according to the current science. In this line, it is important to remark that the speakers are not going to talk about the pain that is caused by specific pathologies or injuries, as the before mentioned rising number of pain cases are mostly chronic musculoskeletal pain conditions without an objective underlying pathology explaining the problem. So the speakers are going to give a 15 minutes lecture, whose content will be complemented by the Q&A session. They are all researchers, but clinicians also, keeping an ongoing clinical practice with patients. So now it is time to introduce our first speaker. His name is Stefan Wittrup McPhee Christensen. He holds a PhD in clinical science and biomedicine, and he's an associate professor at Aalborg University and University College of Northern Denmark. His research and clinical practice is focused on spinal-related pain conditions, and his talk is Neck Pain at Work, What Causes It, and What Can We Do About It? So, Stefan.
Thank you very much. And thank you for that nice introduction. And I'm just working out how to share my screen, so forgive me a few technical difficulties. That's good. Det går nok. Where? Okay, sorry for the trouble we're having. Apparently we can't share the right screen, which we seem to have solved now. So thank you very much, Victor. And as you so kindly pointed out, we only have 15 minutes to cover each area. And this also means that we can't make an exhaustive presentation of all things related to neck pain, but we'll try and show a few highlights of what we think is important to know. And some of the things that I'll be covering in my talk on neck pain will complement what Toldo will be saying later on low back pain. So even though we're not mentioning everything specifically in each presentation, they would still be relevant for the other one. So when we talk about neck pain, one of the things we quite often would like to know is what causes it. And sorry, I'm again having a little bit of problems there. I figured it out. So, and as Victor said, in the majority of cases, we don't actually know what causes neck pain. And this is quite interesting, because I would urge you to go to Google and just type in what causes neck pain. And what Dr. Google is going to tell you is that you will have neck pain because of abnormalities or due to poor posture. But the case is that even when we used very advanced method of investigation like X-rays or MRIs, we can't actually see the majority of these problems. So that stating that it is non-specific doesn't mean that there isn't a problem. It just means that we probably can't identify it with the available technology. Of course, that doesn't mean either we shouldn't use X-rays or MRI scans. They're very important when trying to rule out serious pathology, but in most other cases, it's probably not that relevant. And given that the majority of cases, we don't actually know what causes it, that is probably one of the explanations for why there are so many different ways of defining neck pain. So the most simple way of defining neck pain would be the anatomical location, i.e. the neck. But it could also be the severity of pain. So are you feeling mild pain or more severe pain? And this is the same kind of thought that goes through in the grading that's commonly used for neck pain, where grade 1 would be not really disabling, grade 2 would be a bit more disabling, grade 3 would have some neurological symptoms, and grade 4 would be serious pathology such as fractures, etc. But you could also define it by the duration of pain. So is it acute or persistent? That seems to have some impact on the symptoms that will follow afterwards. And lastly, we can also define it by what we believe is the cause of it. Is it insidious? So did it arise on its own over time without any specific cause, or was there some kind of traumatic event? Or it could be work-related neck pain. And what's important to note here is that even though we would call it work-related neck pain, that doesn't mean it's only at work. It just means the onset was most likely at work, or that it's usually aggravated by work. So even though it's work-related neck pain, it doesn't go away just because you go home from work. And thereby it will impact a lot of other things. One of the things we know is that neck pain alters the way we move. And when you compare those with neck pain to healthy controls, you'll see that they have altered muscle activity of neck muscles, but they would also have altered accuracy of head movements. And a simple way of figuring out if this is the case is ask those with neck pain to close their eyes, turn their head as much to one side as they can, and then find their way back to neutral. And what you would see when you do this is that those with neck pain will be less accurate in getting back to the exact starting position again when compared to somebody without neck pain. We also see altered activity of cervical, thoracic, and axioscapular muscles when doing functional tasks such as moving or lifting something with our hands. And what's interesting is that studies show that those with neck pain would also have a longer activity of some of the muscles during, let's say, a simple lifting task. So it seems that their muscles are active for a longer period of time. And this also impacts on the variability of movement, so of both trunk and arm movement. And this is quite interesting because here there seem to be different findings in acute versus persistent pain. In acute pain, it seems that the variability of movement is increased, which could be interpreted as we're trying to find a way where we can move with less pain, whereas in persistent pain, the variability is quite often decreased. And we could interpret that as you found a good strategy and now you're sticking to it. And with all of these changes, it's not really difficult to understand why the majority of neck pain patients would say that they feel their pain being aggravated when they move their upper limb. But it's not only when we move the head or the upper limb that we see alterations. In fact, it also makes us walk differently. So when you have neck pain, you walk with less trunk rotation. If we ask you to do another task while walking, or ask you to walk in tandem stance or trying to walk a line, then you would also walk slower when you're in neck pain compared to those without neck pain. So in a way, you could say we walk more like a robot when we have neck pain. And to me, that's not really surprising. Just think back the last time you had neck pain, or if you're a healthcare professional, think the last time you saw somebody coming to your office with neck pain. How do they move? Do they move freely, or do they move very stiff, trying to move the body and the head simultaneously? At least that's what I see. So to me, this is, it really makes sense from a clinical perspective. One of the things that have often been blamed as a cause for neck pain would also be posture. And this goes for both low back and neck pain, that poor posture is quite often referred to as an explanation. And again, if you go to Google and just write up posture, you'll get a lot of images where you could see, as you see on the left-hand side, there is this green arrow up to next to the man, where on the right-hand side it is red. So clearly indicating that something is good or bad. And on one hand, if you look at the available literature, there is some evidence to support that there is an altered posture in those with neck pain, both in sitting and standing posture. But if you look at it on the other hand, there seemed to be no convincing relationship of posture and neck pain when you look across different age groups. And this is quite interesting that there doesn't seem to be this, although this is what is the common belief. And again, if you look at the image here, it is clear that there is, with the big red X, there is something that is definitely not good. And the green check mark shows you this is supposed to be good. And this is quite interesting because a recent study by Richard et al. Showed that if you look at the spinal posture at age 17, it doesn't really seem to be able to predict neck pain at age 22 in males. But if you look in females, there seemed to be some relationship with those sitting in a more upright posture having an increased prevalence of neck pain. But the opposite is also true, that those sitting in a more relaxed or slumped posture seem to have less prevalence of neck pain. So if we go back to the figure and look at this, it seems that this green check mark and the red X, at least in this study, should be switched around. And all this tells us is that the relationship is still unclear, and we need more longitudinal studies to look at what is actually the truth. And if we ask people if they favor one posture over another, they will, at least in these studies here, they will say that they don't have an optimal position. And when you ask them to assume an optimal posture, they will change to a more sitting up straight kind of posture. And more so if you look at females compared to males. So again, there seems to be some gender bias here which we don't completely understand yet. But what is interesting is if you ask healthcare professionals, what do they think is a good posture? And in this study by the same group, they asked more than 500 physiotherapists to choose an optimal posture based on 7 different sitting and 5 different standing postures. And what is really interesting is that out of the 7, they found 3 sitting postures, and out of the 5, 2 standing postures that they believed were optimal. So what this tells us is that there doesn't really seem to be a consensus on what is an optimal posture and what isn't. However, what is important to note by this study is that of those postures they chose, both in the sitting and the standing ones, they were all variations of an upright lordotic posture. So it seems that there is some preference towards this. Another thing that is commonly blamed when we talk about work-related neck pain is workstation economics and how you sit at the workplace. And this real cool study here from Switzerland have looked at how are people when they are sitting at the office, and then due to COVID lockdown, how are they experiencing neck pain when they work from home. And they had some really interesting findings. So there didn't really seem to be any difference in neck pain disability, the number of breaks or the number of hours they would work when they worked from home compared to the office. But there was even a small reduction in neck pain intensity when they were working from home, which is quite surprising because you would have thought this should be the other way around, that when you work in a professional setting, you're also going to be better off. But that's not quite what they found here. Another thing they found was that people did rate their work economics poorer at home, but this wasn't associated with disability or a number of work hours. However, what they did find was the number of breaks, irrespectively if you're working from home or at the office, seemed to reduce neck disability, but not really pain intensity. So if you're going to give somebody advice on what to do when they have a neck pain, they're working with a computer, it probably would be fair to suggest them to take more breaks during the day. And this is kind of supported by a study we did in our lab, where we had healthy volunteers sitting in several different sitting postures to perform a 50-minute writing task. And here I've just shown on the image to the right, I've just shown, let me just see if I can get there. Yeah, so here on the right-hand side, we've put people in an upright posture, which is in line with the recommendation of the Danish authorities. And here we've put them in a more slumped position with a protruding chin, etc. What was really interesting is that we found that within 15 minutes, although they were all healthy, both postures caused pain. However, the pain was increased faster in the more slumped sitting posture compared to the sitting upright one. But that all the postures caused pain over time was really interesting, because with that in mind, perhaps we should stop thinking that there is a good and a bad posture, which is the common belief. Perhaps it is more the time you spend in any given posture that seems to be important here. So if we're to summarize what I've been covering now, we can say that neck pain alters how muscles function and how we move. There is a lack of consensus on optimal posture. So if you don't think you have an optimal posture, don't worry about it. And the time in any given posture may be a contributing factor to pain. So this would be worthwhile considering during management. So if you have pain, or you're helping somebody who has pain from sitting in at a workplace, then perhaps suggesting that they try either change between different position, or at least reduce the time in any given position. That would be a fair advice to give. That's my talk for now, and then I will see if I can figure out to send the screen over to Victor. Thank you.
Thank you very much, Stefan, for your very interesting talk. The next speaker is Thorvaldur Skúli Pálsson. He is also an assistant professor at Aalborg University. Thorvaldur is a physiotherapist by background and holds a PhD in clinical science and biomedicine. His research is focused on understanding the neurophysiological, emotional, and cognitive mechanisms underlying musculoskeletal pain, and applying that knowledge to help patients also in the clinical context. His talk is low back pain and pelvic girdle pain at work. What causes it, and what can we do about it? So, Thorvaldur, over to you.
Thanks, Victor. I'm very fortunate to have the help from grown-ups here for solving the technical issues. So I have to remember to give him a big kudos when he goes home today. Good afternoon, good morning, or good evening, all depending on whereabouts in the world you are. I am here to talk about back and pelvic girdle pain at work, what causes it, and what can we do about it. And for that, I have been assigned 15 minutes. So I think we should just get going and dive into it. And we dive into it. There we go. There we go. Thanks. So I think it's fair to say that there's no one single thing that causes it. It's a lot of things. And I think that we are acutely aware of this. And if we were to make a list over things that might potentially increase the risk of us having pain and or something that may increase the risk of us developing chronic pain once the pain is there, the list is pretty large. I've put forward several factors here which is by no means emptying. But I think we can all agree, if we look at the screen, we can see that some of them are predominantly biomechanical, some are psychological, and some belong more to the social realm of things. And this is usually the way things are portrayed in textbooks and articles, etc. But in reality, what we see in the clinic is that almost everybody that has pain and has had pain for a significant amount of time, they have some of these factors present to varying degrees. And what is important for us to be able to do in the clinic is to identify how, if, and to what extent these factors are relevant for the individual patient presentation. Now, today we opted to talk about low back and pelvic girdle pain together because there are a lot of similarities. So apart from being inherently connected because they lie right next to each other, we do see that if we take the risk factors for developing low back and or pelvic girdle pain in relation to work, we can see that there are a range of factors similar to the ones Stefan talked about in the previous talk. So sustained postures, repeated movements at end range, etc. These all seem to increase the risk of getting pain in either area. But we can also see that there are a range of psychometric and social factors that can contribute to the mix and increase the risk of us developing pain. The reason why we chose to have a particular focus on pelvic girdle pain was mainly because a significant part of the working force is capable of becoming pregnant, so the women. And unfortunately, a lot of them need to reduce their working hours or go on sick leave in good time before the delivery because of pelvic girdle pain, fatigue, and sleep problems. So it poses a significant burden on not only the individual who is now pregnant and needs to go on sick leave, but it also leaves a bit of a vacuum at the workplace, which now has to supplement for the loss of a person that has gone on sick leave because of pregnancy. So it's highly important to have that in mind. Now, over the past decades, the pendulum has swung a bit. In the beginning, in the early days, there was a lot of focus on the bio. It was in the 70s when we started focusing a bit more on the psychological parts of pain and emotional elements and the social and the role of social network, etc., on pain conditions. And to some degree, there's been a shift in focus. So we've started to move a little bit away from focusing on the meat and bones and more towards seeing how can we help people developing with the psychological, emotional elements of pain, and how can we adapt our social system towards to better accommodate the needs of individuals who in this case might be at risk of falling out of the workforce. And I think it's important that even though all of these factors are very important, and I would be the last person to say that we should continue focusing on the bio and neglecting the other. I would never go so far as saying that. But I think it's very important for us to acknowledge that the bio does really play a role. So if we think about, if we take, for example, elements that are inside our back, so the meat and bones, and we measure different pressures during various activities, we do see that, for example, the intradiscal pressure increases if we bend forwards with our round back. It doesn't mean that this is a dangerous activity, but it just means that it is different when compared to, for example, walking barefoot at home in our living room. It's very important that we, though, highlight that bending the back does not mean that and adding load to the structures, it doesn't mean that we're causing an injury. So it is so we can't say one causes the other. It just means that when you perform an activity, for example, lifting a heavy box with a round back, you add more load to it than if you, for example, bend your knees and do it with a straight back. We also do know that wear and tear does occur. We do know that this changes as we get older. So the older we get, we see more and more signs of degenerative changes in several aspects of our spine, even in people that do not have any pain, right? So it comes with age. And interestingly also is the fact that if we take people that have pain, and so back pain, and compare them with asymptomatic age-matched controls, it does seem like those that have pain, they have a higher prevalence of pathological findings than people that are asymptomatic. Now, this does not infer any causality. It doesn't say that because you have this, it means that this is the reason for your pain. It just means that these factors seem to be present more often in people that have pain than in people that don't. But it's highly important for us to acknowledge that damage and degeneration rarely comes alone. It is, of course, we have nociceptive input from the back. We have a lot of factors in the back that can all send impulses in towards the spinal cord, which might potentially later at some stage be interpreted as pain. But we all know, but it's well known that emotions, thoughts, and beliefs assigned to the or related to the pain condition very often go and aggravate the symptoms, and can even in some cases be the factor that maintains the symptoms a long time beyond tissue recovery. And here it is really, really important that we stick to the word recovery, because and Morten will touch a bit on this later on. Most people that have an injury to the back or neck or pelvic girdle or shoulder or knee, they recover naturally, even though we don't really do anything to them. So there is this natural recovery involved in any musculoskeletal pain condition. And here it's very, very important for us as healthcare professionals to make sure that whatever advice and management strategies we set up for the patient, that they don't interfere with the recovery, that it promotes and facilitates recovery, but doesn't stand in the way. We do see that people that have a predominant biomedical or pathoanatomical understanding of their underlying pain condition, these are very often, as it seems, people who are less likely to recover. So they seem to be stuck in this situation with disabling back pain or neck pain or pelvic girdle pain. And worryingly, it does seem like a lot of these people have these information from healthcare professionals. So we have to be very careful when it comes to giving our patients advice on and explanations on what the underlying cause for the pain condition is and what they can do about it. Ben Darlow and his colleagues in New Zealand did a very nice qualitative study published in 2013, where they asked patients about what were you told was wrong with you? And it's very worrying to see that a lot of people sit with ideas of something has slipped out of place, something has been worn out and degenerated. You have to be very careful not to make things worse, for example, by lifting. And this is a huge problem for a person, for example, a bricklayer who would spend a lot of their time on all fours moving heavy bricks from one side to the other or something along those lines. So if we are planting a seed in the patient's head that your pain is related to an underlying pathology, the likelihood of recovery has already been diminished. So instead of having such a narrow approach, we need to have an approach which is broader and encompasses multiple domains. 2 years ago, we published this paper here, which was actually on sacroiliac joint pain, but I think it's equally relevant when we're talking about work-related pain, because we're trying to figure out how can we best help managing our patients' pain conditions. And there we put forward 4 bullet points, which to some degree, and I would be the first person to raise my hand and say, well, this is a fairly reductionistic approach to managing something that is by definition very, very complicated. For example, explaining how pain works tailored to the individual presentation. Not only does this require an in-depth understanding from our behalf on how the pain system works, but it also requires quite good clinical skills for us to be able to extract all the important information for the patient and try and make sense of it in the context of the pain condition. But we'll get to that later. Constructively address all the unhelpful beliefs that might be present, promote reassurance, because we do know, and if we think about it before, you can have pathological changes and still have a good life and even be pain-free. So it doesn't mean that you are necessarily stuck in a state of pain for the rest of your days. And then our management plans has to be aligned with all of these points. Now, to give you a little better idea of how this can be put together, I'm going to use the wise words of Peter OSullivan and his groups. Throughout the last decades, they've worked on an approach that tries to encompass all of these many domains. So instead of trying to find the magic bullet for how to cure back pain, they've acknowledged that back pain, and for that matter, any musculoskeletal pain condition, is related to multiple domains. So in the approach, it is very important to identify all of the factors that might be underlying the painful condition. So not only the physical factors, in this case, could be sitting, standing, lifting, whatever, but it's also the emotional behavioral responses that are related to the patient's pain condition. And of course, thought processes related to whatever activities that evoke pain. But this needs to be mapped out thoroughly in the subjective assessment, but this needs then to be further addressed in the objective assessment. And here you would try and focus on the activities that the patient is having problems with. So if it's sitting, you would use time to evaluate the sitting position in the patient. If it's lifting techniques or standing, you would also focus on this. But here it's very, very important, as Stefan also touched on, that we're not trying to figure out what is correct and what is wrong. We're not trying to get the patient to adapt a more correct lifting technique. We're simply trying to get an understanding of whether modifying the way the patient is moving and performing a given activity can actually modify the pain experience. So instead of changing it towards something that's more right, we're simply just trying to offer the patients more alternatives to performing any given activity. So it sounds pretty simple, but it does require good clinical skills. But with the training we get as healthcare professionals, if we put effort into it, I would dare say the majority of us would be able to set up a very good and coherent management plan, which could look like something like this. So first of all, communicating our assessment findings is key. So it's not enough that we perform an evaluation and we create an idea or a picture in our head of what needs to happen. This needs to be explained thoroughly to the patient, because at the end of the day, it is the individual that needs to be able to make sense of his or her specific pain condition. And this can only be done if we can relate the assessment findings to the pain condition the patient came because of. And in the management strategy, the focus would always have to be on valued and meaningful activities. And here, valued and meaningful activities to the patient, but not to us. So if it's the lifting that's problematic, we have to address that. And that could be part of the exercise. The same goes for sitting positions, etc. Often we would use exercises, so typical exercises performed by a physio would be 3 sets of 10 of exercises aimed at strengthening the back, for example. But it's very, very important that for it to be meaningful, it also needs to be transferable, because the patients will also feel, and rightfully so, that and think, how is this going to help me be better able to lift the boxes at work or sit for 4 hours in front of the computer? And the entry point, so the level of the difficulty of complexity, it needs to be individually tailored. So it depends on the individual capacity. So find an entry point and then progress it from there. But this, of course, opens up for the possibility of using work and activities of work in the process. And Morten will touch on this in his talk later, but if possible, try to integrate the exercise and management plan into the activities at work, because this will seemingly facilitate returning back to work and or limit the need for taking sick leaves in long or short terms. So now I will virtually give the microphone over to Morten. Thanks for your attention, and I'll see you in the Q&A session.
Thank you very much, Salvador. This is going very well. Sticking to the time, etc. Now it's time for the third and last talk carried out by Dr. Morten Høeg. He's an assistant professor at Aalborg University, and his work is focused on improving care for people with chronic pain. And he's also doing research, education, and clinical practice, and tons of scientific dissemination through several scientific societies such as EFIC or the Danish Pen Society. His talk is Spinal Pain at Work. Spinal pain at work. Cool working, not sick leave, be part of the solution. So Morten, when you want.
Thank you very much. I hope that you see my slides and hear me. Otherwise, it would be wonderful if someone would let me know. I'm very happy to talk about this very complex and also very important area of making work part of the solution rather than simply a goal in itself. I'm taking a standpoint from some of the experiences I've had from being part of a trisection program published in the National Danish Radio, discussing with professors Jan Hartwigsen and Andreas Holdemann regarding the role of pain and work and low back pain sort of mixed up. One of the things that came out of our radio programs was there was a lot of confusion regarding loading and back pain. So that's what I'll be taking my stand on. One of the things that people was really careful about, or that many people would reflect on, was not so much the knowledge workers, the people sitting in front of computers. There are quite good solutions, and as Stefan was talking about earlier, simply getting up and moving, easy exercises have been shown to be quite effective for this type of computer-related neck pain. However, in the case of loading, there seems to be some specifics that might be relevant to go into. So what I'm going to do is I'm going to take a very pragmatic approach towards looking at load and how that relates to spinal pain at the workplace. I should say that my approach is also based on my understanding of neuroscience. So I will be having this sort of idea whether or not we can understand load as a means of transducing signals through the nervous system, or you could say nociception if you like. And I acknowledge that the people listening to this webinar might be of very different backgrounds. So if some of what we are saying is either too narrow or too broad, just use the Q&A session afterwards. And that's been said, we will try and restrain the talks to about 3 times 15 minutes, but we're happy to address any questions afterwards. Also in this talk, what I will try and do is focus on solutions that involve the workplace. But first of all, the question that really is eminent, I think, is whether or not we can establish causality between load and back pain. That is, if we could remove load, would we also have an impact on low back pain? In order to answer that question, with a few colleagues, we are preparing a manuscript looking at the Bradford-Hill criteria and those criteria in relationship to the causality and the relationship with low back pain. So what you see here is a table that I made up from the results that are in the manuscript. And I do apologize if it's a bit crowded. I'll talk you through it. So first of all, if you look out on the left-hand side, you will see the Bradford-Hill criteria. Under the section called question, I have added some questions that I will go through briefly. And then I have two sections with colored responses. The first one is whether or not there is a combination or whether or not there is an association between the Bradford-Hill criteria and having injury or becoming injured, or receiving or becoming degenerative. So whether or not loading, for instance, can cause or be related to severe degeneration of the spinal tissues. In the final column, you would see this idea of non-specific pain, so pain with a multifactorial background. And if you are more into the terminology of the pain world, you could say that the first column would be asking the question, is there a direct relationship between load and nociception? Whereas the second column could be, so the non-specific column could be, is there a direct relation between loading and nociplastic pain? So first off, is positioning of your body. So there's a consistent finding of awkward postures, for instance, that might aggravate pain. So is it so that awkward positioning or load is associated with a higher incidence of injury? Well, you could say there is. If the load is high enough, definitely that can cause injury and possibly also degeneration. But there doesn't seem to be this strength related to the non-specific pain. If you look at the consistency of loading being a risk factor for injury, again, this seems to be quite difficult. If you look at least the working literature, we have the majority of the world would have legislation to protect workers from having severe loading. So the literature does seem not to come up with any findings that indicate that loading itself will lead to injuries if you stay below a certain amount of loading. Again, you could go to the old IASP papers if you want to have more insight to that. Again, and also if you look at non-specific pain, there isn't a consistency either. Probably most interesting, is it so that loading comes first and then comes either injury or non-specific pain? Well, you could say that loading comes first and that might lead to degeneration, but you cannot say the same thing about non-specific low back pain. Then the question regarding dose-response relationship. So if you keep dosing or you add an intensive dose of loading, will it lead to injury or degeneration? Well, it might. Again, this would be extreme cases. Perhaps you would see this in certain workplaces that are similar to athletes. So the athletic world or the top athletes perhaps. But not in non-specific low back pain. The same is true if you look at whether or not loading leads to similar outcomes in a range of people. What you would see is that some people will have degeneration without having pain, and some will have pain without having degeneration. So there's a bit of mismatch on that case, especially if you look at non-specific pain. What about the odds ratio? Well, this is one of the places where you actually do find an association. So there is an increased odds ratio of experiencing non-specific low back pain if you are working with load. So that's something we'll come back to. I think one of the most interesting things coming from my perspective, at least, is that we do have alternate explanations to some degree for understanding degeneration. So think about osteoarthritis, which we now understand as a disease in its own right, not necessarily a consequence of loading, but also, and definitely true for non-specific pain, we have alternate explanations to understand why it might hurt to be loaded if you are hurting already. So we have alternate explanations for that, which in this case would move us away from understanding causality. And then is the quality of a high enough, is the evidence of a high enough quality? it seems to be, the evidence seems to be of high quality to actually put an association between loading and either injury or non-specific pain. Again, this suggests that if you are in pain, it might be aggravated by loading because the association doesn't necessarily say anything specifically about causality. And then finally, and perhaps also very importantly, would it be a good management strategy to unload? You would probably know this in the workforce as ergonomic or advice on back schools, this sort of thing. And we have evidence to suggest it doesn't really matter on non-specific pain, whereas it might have some sort of reduction in pain if you have an acute injury. So if I wanted to summarize on this, I would say what is necessary and sufficient to establish whether or not there's actually good evidence for a relationship between loading and either acute pain or non-specific ongoing pain. I would say that, first of all, load has to, so changing load, reducing load should reduce low back pain. Also, it has to provide a useful prognosis so that you know much more load or less load will have a different prognosis. And then finally, load management should be a guide to treatment, not necessarily the entire treatment, but possibly a guide to treatment. And I think we can safely assume, based on the presented ideas here, that this is not the case. Of course, you can disagree with this way of positioning the Bradford-Hill criteria, and I'm happy to discuss that in the Q&A session afterwards. So if unloading is not the solution, what is, you could say? Well, first of all, I want to talk about some of the studies and my colleagues at the University of Southern Denmark have been doing for quite some time, suggesting that actually spinal pain is common way before people enter the workforce. If you look at the figure here on the right-hand side of the slide, you can see these are brand new data from a study that we have just recently submitted, looking at, this is a cohort of more than 5,000 adolescents from age 5 to age 20, assuming that these will be not in the workforce, or the majority at least will not be in the workforce. But you see they have back pain and neck pain as well as pain in any other region of their body, with an average of something that would be an equivalent of mild to moderate pain, so between 3 and 4. And these are all people who have signed up for treatment in a primary care clinic. So these are patients who are the ones that seek care, so the ones that I and my colleagues would see in the clinic. Also, as we talked about before, it seems that loading and awkward positioning of the spine is associated with tissue strain, but not necessarily with pain. So as you heard Stefan talk about earlier, you could see that if you put someone in a position, it really doesn't matter what type of position it is, but if they stay in that position for a prolonged period of time, being pain-free in the beginning, the time itself might actually be the factor that we should care about, not so much the positioning they're sitting in. But if you, as Torvaldur said, if you look at the strain to the tissues and measure that, you do see a very nice difference in the way that, or association between loading of the spine or sitting in specific postures and then increased tissue strain. So you could argue that maybe this tissue strain is then leading to structural and degenerative changes. However, even if it did, studies seem to suggest that having degenerative changes do not correlate with neither pain nor activities in daily life. That includes work, of course. And also having these degenerative changes, as we talked about before, will not guide treatment, not guide diagnosis, and not necessarily be a good standing to work towards self-management on, and I'll come back to that. So it also seems, which I think is a really important point as well, that if we use biomedical explanations, that is using either tissue-based diagnoses or giving biomedical or biomechanical explanations to back pain, such as you strain your tissues, that is why you hurt. This might actually lead to over-treatment, over-diagnosis, and extreme worry and perhaps delayed return to work, as I will show you later. So let's just have a second and think about how would you work if you had a headache all day? would you be as efficient as you would without a headache? I assume you wouldn't. If you had a back pain, would you be as efficient? And I assume you wouldn't. So this idea of pain as an interfering media in your life, we can all relate to that. And I think we might want to, at least for now, try and change the way we understand pain in the workplace. So if you are actually, so to speak, carrying pain with you from early life into your workplace, then obviously that pain is going to be affecting your work. But the thing is, work did not cause that pain. So interfering only with only with work, or even worse, staying off work because you are in pain, is unlikely to be the solution. So if you could treat the headache, let's say you were just hungover, that would be an easy one to treat. Time does its work. So a day, maybe 2 after, depending on your level of being hungover, or perhaps age, or a combination, could cure it. So you would be back on your game again after a few days. But what if that pain is there all the time? What if you had it for 5, 10, 20 years and you haven't managed to work around it? So having the pain and still being able to perform, how would that influence your ability to stay in the workforce? Quite massively, I would assume. So the sort of boiled down points that I think we should be considering when we talk about work-related non-specific spinal pain is, first of all, that loading seems to aggravate existing spinal pain. So if people have pain, it seems to be true that being in pain, coming into the workforce and then doing heavy lifting, for instance, is an aggravating factor. But simply removing lifting or having aids to support and to help you do the lifting is not going to remove the back pain. So back pain itself is a problem, and it just has influence on the ability you can work. And in the case of loading, it actually seems to be an aggravating factor. So we know this because recent evidence, that I'm here referring to the Niemann pain reports systematic review, you can see in the references. They say that high pain intensity, carrying heavy loads at work, and difficult working decisions seem to be consistent findings in the association between who is hurting at work. So if you are hurting and you have these things, you're more likely to be interfered with your work life. Also, and very interestingly, work and loading at work seems to have a different impact on people compared to doing exactly the same amount of lifting, but in your leisure time. So for instance, going to the gym. We don't understand completely what it is. Well, actually, we don't really understand it, but this physical stress dilemma, or this exercise activity dilemma, is something that they're working on in the group with Lars Andersen and Andreas Holderman, I mentioned just briefly before. And also, if you look at the figure on the right hand side, you can see that loading actually increases the risk of sick leave, not necessarily pain in that causal relationship, but if you have pain and you are loading, it does seem to fit that the more you are loading, the more likely you are to be off work. And having established, or at least I have postulated, that there is no direct causal relationship between loading and back pain, this represents a sort of dilemma. Unless you look at it from a different perspective, which is, what if exercise, or load in that case, is simply viewed on differently? So imagine that you think that loading at the workplace is causing pain. That doesn't give you any options to actually change things. And if you're an employer and you are listening to your people, the staff saying, we get back pain from lifting and it increases with age and increases with the load we're giving or taking, you might be, feeling and need or desire to find new people or to get instruments to support them in their daily life. But what if adjusting that life, that work life, that loading, being flexible about solutions, maybe being more embracing more patient managed or worker managed programs, so that workers themselves could find out ways to manage the load in manners that fit to them. This is similar to what we would do in the gym, isn't it? So you wouldn't give a specific set of exercises for everyone in the same gym. You would give individualized care depending on what they want to achieve, what their load demands are, but also how they are as persons and what they are perhaps feeling when they're doing it, such as pain. And then finally, and that's something I'll touch upon in my next slide as well, is that there are a range of misconceptions. So just like my colleagues have alluded, I also, of course, embrace the fact that just looking at the bio or the mechanical aspects of pain really cannot give us any solutions in itself, but it might be things that we can use to approach work in work-related pain in the loading environment. But definitely we need to understand that misconceptions about, for instance, what causes back pain, how can we treat back pain, is it dangerous to move, these sort of things need to be addressed as well. So coming back to my question and finalizing my talk, can work be therapy? Well, first of all, what I would like to say is if you look at, for instance, the Lancet papers on non-specific low back pain, you can see that first-line treatment for chronic pain include education and advice to stay active, and exercise. It also includes cognitive behavioral therapy, but in this case, I'm just focusing on these three. So I would argue that exactly the same things should be used if you look at work-related back pain and possibly also neck pain. But how does exercise differ from load-based work, you could say? Well, first of all, and as I said before, if you do exercises with back pain, you're more likely to seek information and support and advice on how to do your lifting without aggravating your pain. Whereas it turns out that some workplaces, especially maybe those who are more blue-collar type workplaces, they lack that flexibility of adjusting and adapting to the needs of the person. The knowledge base, which we talked about before, understanding what pain really is, understanding that there isn't an association between loading and pain so that you can easily load your back without being at risk of having chronic pain in your back. Those two are simply not causally related. So whether or not you will have back pain when you lift is not caused by lifting, or simply said, you cannot accumulate the amount of load you are lifting and then by that knowing that in the future you will have chronic back pain. It's simply not true. And definitely what we also need to understand is that absenteeism does require less effort than actually staying at work. So we have a lot of what's considered black flags. So legislation, for instance, it seems, I'm talking out of a Danish context here, so I wouldn't know if that goes for everyone, but in a Danish context, it's much easier to stay off work than actually returning to work if you're not cured or if you still have pain. But if you have non-specific pain, chances are that that pain is going to be there again and again and again. So what are you going to do? Stop working? Or how are we going to solve that? Trying to come to a few solutions here, I would recommend that we inform ourselves with what we are doing exercise-wise and use it for work as therapy. Or in other words, if I would say to a patient, you need to do exercises, why not simply say, you need to go to work. This is how we will adjust it. This is how we will manage it. This is the flexibility the workplace needs to show in order to actually accommodate you as a worker in this workplace. Of course, that requires a lot of flexibility. That is why we do not, we also need to include education. And if you look under the second dot on the education, you can see that it's not only the patient or the workers, it's also the employers and the decision makers, and importantly also the healthcare professionals, so that we give out the good advice, the right advice. And then self-management is definitely the goal here. I actually lost one of my references here. I want to point you to a recent article that is in press now by Alice Kongsted and colleagues in the Brazilian Journal of Physical Therapy with, it's something like 10 bullet points to remember when you're treating non-specific pain, something like that. There's a lot of wonderful material in there and giving you a lot of insight into how to approach management of non-specific pain from a patient-centered approach rather than a sort of broad approach or expert-based approach, if you like. So can work be therapy? Well, yes, it can. That I would argue. And having just gone through this, I think it might be more of a, inspiration for questions and answers afterwards. But I hope you will challenge us and give us some of your feedback in regards to this talk. And speaking about feedback, just before I end off, if you would like to tell us how we did on this, you can go and just open up your camera and point the camera on your phone directly at the QR code, which is now on your screen. And it will lead you into a web page called menti.com. And in there, you can do a short questionnaire to let us know how we did. Thank you so much. And back to you, Victor.
Thank you very much, Morten, for your interesting talk. Now it is time for the Q&A session. I guess that we have around 5 minutes for a few questions. I will start with, I encourage you to type your question in the Q&A section. What is non-specific low back pain? Is there any specific low back pain? I guess this is for Morten or Torvaldur.
Mm-hmm. Could you repeat the question?
Yep. What is non-specific low back pain? Is there any specific low back pain?
Yeah. It's I think it's a good and relevant question, because if we look into the literature where they've actually gone ahead and scanned people to see is it really non-specific, you can, in the majority of the cases, you can always find something, but attributing the findings to the symptoms you have is very often, like I touched on that, Morten also addressed it in his talk, it's very, very difficult. So in the cases where there is no apparent pathology, so a systemic disease, fracture or malignancy, you would call it non-specific, knowing very well that this would then include more than 85% of all cases of non-specific low back pain. And it really just tells us that you have back pain, but we do not really know why it's there, but it's not related to specific pathology.
Good.
Well, if you wanted to be specific about back pain, I think one way to go about it would be to address it as a serious pathology. So, for instance, a specific back pain could be the result of having a fracture, or it could be, an infection. But these are commonly not seen in work, and partly so because of the fact that we also are having legislation to protect our workers, which we should have. And I don't know if this is more prevalent in countries where the legislation is different, but at least from our perspective in Denmark, the legislation protecting workers is quite sufficient, so that the amount of accidents we have that could lead to specific low back pain is actually at a very minimum. So they're not the ones that are really causing us or them the problem in everyday life.
Yeah. Another thing that I want to add to that, in most countries, our ability to detect and accurately diagnose specific pathologies is fairly good. So the healthcare systems around the world are very well equipped to deal with these. Capturing them, of course, there are temporal aspects to it. When do you actually get the diagnosis? That might vary quite a bit. But in general, I would think that we are fairly good at finding these. So it's the rest, the bigger group, which we struggle a bit with.
Thank you. I think this question is for Stefan. How will you identify if posture is a contributing factor for someone with neck pain?
Well, thank you for that question. It's very relevant, because when is posture actually an issue? And I guess the simple answer to it is ask the patient. So when is it they feel pain? Is it when they've been at at the office for 2 hours sitting in the same position? Does it go away when they have the first coffee break of the morning? So all of these things that can tell us a little bit about when is it they feel the pain, and for how long time does it take before it actually starts aggravating what they feel. And when they then do something else, how long time does it take before it goes away? And if there is this pattern with them sitting in for a prolonged duration in a certain position and it causes them pain, then it would definitely be worthwhile trying to see if you somehow can modify this. But saying that, it's also important to state that it doesn't seem like there is any right or wrong posture. It's more about the time that you spend in it. So just choose a different posture. It doesn't matter which one, as long as it's not the one causing you pain.
Good. I think we have time for 1 or 2 more questions. Janet, please let me know if we still have time for doing that.
Yeah, sure, you can go ahead. There's no rush.
Okay, let's do 1 more. This one, self-management. Does it mean exercise, home exercise program? Serjan is asking for clarifying it. What does self-management means?
I can have a go at that, because that's sort of where the reference I was alluding to is going. I think we need to understand that self-management is much more than simply asking the patient to do something. It's more about giving the patient the tools they need in order for them to manage their pain in their daily life. I like to use the metaphor of managing non-specific pain, not like metaphorically getting into a taxi and having, you know, the expectations that when you get into the clinic, the taxi driver, or i.e. the therapist, will drive you to your end goal. Rather, you should see management of non-specific pain as a sort of getting a driver's license, so to speak. So it's more about understanding the theory and using that in practice. So think about management and self-management more in the direction of learning how to drive a car, rather than getting in the back seat and being driven in a taxi.
Okay, thank you. I guess we have time for 1 more question. And then we will finish. Is there a good measure of functional recovery in low back pain? For example, range of movement, EMG activity during movement, or overall increase in movement, in addition to pain ratings, of course. So what would be the best metric for monitoring low back pain recovery?
Well, in this case, it would be people getting back to work, wouldn't it?
Yeah.
I'm a strong believer in functional outcomes and functional measures. So if people cannot work, then I think we should aim at getting them back to some sort of work. And I'm not saying this, or it doesn't have to be paid work, but it could be any sort of identity and perhaps, you know, engaging. We have a Danish study suggesting that for the majority of people between 20 and 60, workplace is the go-to place for your social activities. So it's the majority of your social network is related to your workplace. So imagine not having a workplace. That really tears away a lot of your social network, which will definitely be a subsequent and an additional factor that could aggravate your pain.
Yeah. I would like to weigh in on that also, Victor, if that's okay. I think it's Stefan touched on it in his talk. If we look at so the question sort of, can we quantify, what are the best measures to quantify performance, so to speak? And we can see that normal healthy people, they do all sorts of things, and we do see here in our labs where we're not going to say fortunate enough, but we've done studies where we induce experimental pain, and then we can monitor what happens in the muscle system when you're in pain, and then we can compare it with a non-painful condition. Then we can see that people respond very, very differently to it, both regards to what type of which muscles they activate more during the pain condition. Some people actually engage fewer muscles, but the net outcome always seems to be this sort of tightening up, which is a very common finding in acute pain, both experimental and clinical. So I think if we want to do it sort of in an n=1 setting where we want to figure out what's the best measure for my patient, I think we have to be able to determine what are we trying to achieve, because we have no idea how the person performed before they had their pain. So changing them towards something that we don't really know and is highly variable can be very challenging. So I'd agree with Morten on that it's sort of patient-reported outcomes, ability to return to work, the global perceived experience of improvement, like how's it going? So the pragmatic approaches I would be a huge fan of.
Thank you very much.
Can I take one question? There's a guy called Madhu Mita Nayak, I'm sorry for the pronunciation, who is asking about structural relationships with, or pathology and degeneration relationship with pain. And then another question here that from the same guy, I assume, can we entirely rule out postural, structural and biomechanical factors for pain? So I'll try and condense what I just said and see if that makes sense. If you want loading to hurt, say if you want a specific position or specific loading that is not directly damaging your tissue to hurt, the only sort of understanding we have of that scientifically would be that there is a sensitization of the nervous system peripherally or perhaps centrally, meaning this sort of maybe nociplastic type of changes in the nervous system. So if there is inflammation, for instance, in the case of osteoarthritis, loading in that case will actually be able to somehow generate the action potentials that we think lead to pain. So if you manage the inflammation, the pain should go away. That would be the ideal or case that we can discuss. However, there is a range of people who do not have signs of inflammation but still have pain. So you could say that the tissue stress is only relevant, or loading is only relevant in the case of inflammation. Otherwise, we don't understand how loading is transduced into nociception, and therefore we don't understand how loading actually relates to pain. Having taken that approach, you can also use the approach that I did before with the Bradford-Hill criteria and suggest that actually the evidence doesn't show that you will find a good relationship between loading and pain unless people have pain before they start loading, but not the other way around. So the chances are that you will be, you will have pain for reasons we don't understand, and once you have pain, loading can aggravate it. I don't know if that makes any sense, Madhu, or otherwise feel free to reach out and discuss it via email.
Good. I think that's it right now. Janet, if you want to close the webinar.
Great, yes. Thanks everyone for joining us today. We appreciate your participation in this webinar. The recording will be available shortly. Everyone that's registered will receive an email and will also be posted on the IASP website. We look forward to seeing you at future IASP programs, and we hope you'll join or renew your membership today. Thanks everyone.
Thanks, guys.
Bye.
Thank you.